So if you want to go ahead and do our intro and then lead right into
Okay.
it, we're recording
Okay.
right now.
Well, so I want to thank everybody for attending. My name is Greg Skipper, and I'm the medical director at the Center for Professional Recovery in Malibu. And we have been producing blogs and then also webinars on physician health. And so you can find our blogs and video packages that are on YouTube at the website centerforprofessionalrecovery.com/blog. Um, so if you're interested in some of the other topics, we've covered quite a few different topics regarding physician health. So today, um, whoops, let's see what's happening. Today we're going to talk about this subject that's a little sensitive and I'm a little nervous about it. But, medical boards, and, I really felt like somebody should talk about the fact that protecting patients and helping physicians are not mutually exclusive. So we'll delve into that, and I'm going to invite people uh, points along to make comments or ask questions. So it's often cited in many boards. There's different wording here and there, but that the mission of the medical board is to protect health consumers through the proper licensing and regulation of physicians and surgeons. So it's often said that that's the mission of the board and not to help doctors. Um, the question I guess I'm posing here at one point anyway is, must patients be protected from their physicians? It's kind of a scary question. So how important is it that patients trust their physicians? If patients do not trust physicians, are they less likely to seek appropriate care? And if patients are afraid to seek care because they don't trust physicians, is this a danger to their health? And I believe it is. As cited in one article, trust is a fundamental aspect of the patient-physician relationship. So, I believe that we need to promote the idea that physicians are trustworthy and competent so that patients will seek appropriate care. And if they don't, that can be a danger to public health. So anything that leads to the promulgation of the belief that physicians are untrustworthy or dangerous can or may actually be detrimental to public health. Now, I believe it's the job of the medical board, and of course, the medical board has to decide for itself. But I believe that one of the primary jobs of the medical board is to assure that licensed physicians are qualified to practice. Patients should not be burdened with the task of wondering if their doctor is competent. So, I think patients should trust the medical board as well as their physicians. So promoting the idea, intentional or not, that doctors cannot be trusted increases risk, in my opinion. So who benefits from promoting the idea that doctors are dangerous? Well, I believe the media can benefit because the public definitely has sort of a more morbid curiosity about bad doctors. All you need to do is Google phrases like physician harms patient, physician disciplined by medical board, bad doctor, things like that. And you see almost every day there's articles that the media picks up. So there's a real interest by the public in seeing this kind of thing. And I think it has to do with cognitive dissonance. It's just so weird to think that the doctors that we're supposed to trust, violate that trust. I think it really, just like when politicians fall or anybody falls, people are sort of morbidly curious about these things. So the media pick up on that. Another group is consumer advocacy groups. They make their living, they raise money by, quote, protecting the consumer. And so they can benefit when you start saying, well, there's bad doctors out there, we need to protect the public. And then, of course, attorneys, they benefit from the idea that doctors are dangerous. And, I think in some ways, medical boards, unfortunately, can fall into the trap of, feeling like they need to report high numbers of, investigations and actions because of sunset laws and stuff like that. So that can be a trap that is to be avoided, and that's what we'll talk about a little more. So what about doctors and their patients? I think the vast, overwhelming majority of doctors are in the profession because they care and they want to provide good patient care. So there's very few doctors that harm patients. I'm thinking it's analogous to the relationship between parents and children. So pediatricians are responsible to take care of children, but they don't only treat the children. They know that they must care about the parents as well in order for the child to be healthy. So in the same way, medical boards really should care about physicians and promote their health and well-being because it's good for patients. So it's pretty clear that in the literature that healthy doctors provide better patient care. Doctors who are physically active are more likely to promote exercise. Doctors who quit smoking are more likely to promote smoking cessation. There's many other examples of how, when doctors develop healthy habits, they are more likely to transmit those to their patients. So these are some references that document that. Erica Frank, in the first reference there, has done a lot of work in this regard. So I think I'll pause there for 1 second and see if people have questions or comments before we move on. Does anybody disagree with what I've said so far? Go ahead, Mr. Pacifica.
Okay, Greg, first of all, thank you very much for inviting me. Look, I could speak to you for 12 hours, amplifying everything that you've said. I will try very hard not to monopolize the conversation. I came here to listen to what you all said. Just some points very briefly.
Yes.
Of course, it is absolutely correct that the notion of protecting patients and supporting doctors are not in conflict, but it's absolutely essential. Look, I'll keep it as brief as possible. The job of the medical board, through its variety of regulatory functions, is to maintain and promote higher standards of care and better practice. For the overwhelming majority of doctors, as you said, they are well-intentioned and well-trained, but and it is, you have one regulatory model to deal with them. That's the overwhelming number of doctors. There are a small number of doctors, and if anyone here read some of the cases that I read on a daily basis, they will know that the profession is being protected by excluding these people from practice. But that's only a very small number. So it is completely wrong to focus on disciplinary actions by medical boards as the primary means by which they promote higher standards. Secondly, if you only look at disciplinary actions, that's what they call downstream regulation. The harm has already occurred. What regulation is all about is looking upstream. How are doctors trained, starting with the medical school curriculum, continuing medical education, and most importantly, the culture in our institutions which are delivering healthcare. You want a culture of open disclosure, continuous improvement, of everyone working together to raise standards. That's the absolute key. And the Medical Board of California has just gone through a sunset process. If anyone saw it, it can only be described as brutal. We were told exactly along the lines as you said. Why don't you discipline more doctors? Why don't you revoke more licenses? Now, I put this to every member present here. Let's just say you had a decision to make. Where do you want to live? And you had two places, city or town A and city or town B. And someone told you, well, let's say city A, they've got twice as many people in jail for violent crime. That must mean the justice system is so much better there. Why don't you move there?
Right.
That's ridiculous. Maybe they have more people in jail because they got more crime. Hello, is there anybody home here? So, I support everything that you're saying. And doctors need to be supported. Now, in every other jurisdiction in the world that I'm aware of, a central issue for the regulator is dealing with physician wellness, depression, burnout. It's a simple fact. We don't have enough doctors. They're being overwhelmed, many. They need support. They need guidance. And the focus on simple discipline is a terrible mistake. Now, look, I've spoken enough. I'll shut up and I'll listen.
Wow, I'm so glad you spoke up, and what a delight to hear what you just said. I'm excited about that. So we're on the same wavelength. So, I just wanted to point out, there's this great book, Medical Licensing and Discipline in America, that was written by Johnson and Chaudhry, that reviews the history of medical boards. States were given the right to regulate health through the Bill of Rights. States began licensing physicians in the mid and late 1800s. And I went to a lecture a few years ago at the FSMB, the Federation of State Medical Boards, and somebody talked about 3 eras of medical licensure. And I think this is kind of interesting, that early on, medical boards really were there were charlatans and people that were incompetent because they weren't even trained. So early on, the boards really were into being sure the physicians were qualified because they'd been to school, graduated from a medical school. And then the area of examination, where not only did doctors need to show that they'd been to school, but that they also can pass a standardized exam, which used to be called national boards. Now it's the USMLE. And then it really only in the 70s, we may have entered, according to the speaker, entered the era of investigation, which, you could wonder what's happened in our country. If you look and compare what's happened here in the last 40 years or so to what's happened in Europe and other places, we have been much more in the United States, much more into pursuing this sort of thing, encouraging complaints and pursuing investigations and actions. Not that there's not many, as Mr. Pacifica said, there's many times that it's warranted and important, but not as a primary focus, in my opinion. So, just as he said, by the way, Mr. Pacifica you're the executive director for the Medical Board of California. So I'm just really honored that you're here. But, this is what sounds like you faced at the Sunset Review, is needing to show that you're protecting the public. And the easiest way to do that is through the numbers of investigations and disciplinary actions. And that may be the wrong primary focus, as you said, which I think that's what I'm trying to get across. And I think too much in the past that I've been to board meetings and read board meeting minutes is, particularly the consumer advocacy groups come in and really want the board to narrow its focus and increase disciplinary actions. And that's can be dangerous. So as you said, physicians are having problems. There's, this one study showed 25% of physicians um, uh, had depressed mood in the past year for at least 2 weeks. Depression was more common in female physicians and primary care docs. Anesthesiologists report there were 45% that reported, anhedonia, just not feeling joy anymore. And mental health related stigma remains a serious, let's see, I can't see that, serious unaddressed issue that hinders both patient care and welfare, patient care and physician welfare. So the stigma issue is big with regards to mental health. So I want to touch on this subject, which most of you probably know has been in the, promoted as a concern, and that is the questions that medical boards ask for licensees when they're initially licensed or when they, renew their license, can actually discourage physicians from seeking appropriate care. And there's been concern that the suicide rate among physicians is higher because they don't want to seek care. And I think doctors in general are reluctant to seek care. They get curbside consults and talk to colleagues more likely than actually going and getting legitimate care. And it's because they'd rather be doctors and not patients, in part. And that can be dangerous. So in September of 2016, in California, a bill was passed by the legislature authorizing the Medical Board of California to establish a physician and surgeon health and wellness program, specifically for the early identification and appropriate intervention to support a physician and surgeon in his or her rehab from substance abuse. But, it's been 5 years, and maybe one's coming, hopefully soon, next year or two, but it's been 5 years and no program.
Greg, can I just update you there very, very briefly?
Please.
Just to say that in the year that I've been there, it's been an absolute priority to get the program up and running. We have, during my tenure, drafted the regulations. We're working to get that up and running as quickly as possible. However, the program itself doesn't have the non-adversarial nature that I think is required here. It's the kind of program for which, if there is any lapse, there's mandatory reporting and mandatory disciplinary action. It seems that it's not going to achieve the goal of self-referral, and it is being used too much simply as an adjunct to the disciplinary process. A condition of probation will be to enroll in the program. Having said that, it's what we have. We need to get it up and running as quickly as possible, and then hopefully fine tune the program as we go on.
That is so great. I'm so glad you're attending this, and I'm glad to hear what you have to say. It's so in line with what my views are in this webinar is about. So, I don't want to disparage what you're doing. It sounds like you're doing great things, but, I think it is kind of exemplary of the problem that this development of the physician health program has been encumbered and slow, when over this past 5 years that the program is stalled, things like this, the Senate Bill 1448, which is the Patient's Right to Know Act, where the the medical board has the ability to require doctors to divulge their probation. And my comment about that would be, certainly doctors end up on probation because of things they do, but they should not be allowed to go back to practice if they're not safe. And I know that the board knows that. The board wants these doctors to be safe. That's partly why they're on probation. But to require the doctor to divulge the details really doesn't help with patient safety, in my opinion, because this doctor is safe. Otherwise, they wouldn't be practicing, at least under the conditions of their probation. So is it really necessary? Does that cause problems with patient trust? Does it cause problems with doctors wanting to obtain help that need it? That's my concern. The other thing that I saw that the board did during this interim, when they have not developed a physician health program, is develop this app where, there's a positive aspect of this, I'm sure. But again, it just shows what the focus has been, is develop the app so that patients can put an app on their phone, put their doctors in, and then be notified if their doctor has a disciplinary action. So that lends itself to the thinking that the board is more focused on this side of things. And as Mr. Prosificus said, I think it's really going to be good for the board to let people know that they're also concerned about the other side. And I think developing a good physician health program is a step, and there's other things that could be done. So I do want to touch on this recently released policy. So the Federation of State Medical Boards, as you guys know, has been around a long time, and it's a federation of the medical boards in the United States. 71 boards or members, and so they have policy statements. So this is a new policy statement on physician illness and impairment towards a model that optimizes patient safety and physician health. I think Mike Barron was on this committee that helped develop this. So this document mentions, sorry, somebody's blowing a thing out there. It'll go by in a second. This document represents recommendations to protect the public through assistance of the licensees. And it mentions that early detection, evaluation, and treatment and monitoring of a physician with an impairing illness enhances the board's ability to protect the public. So again, focusing on the positive side rather than discipline side. The other quotes from this document, which you can find online, by the way, if you just Google FSMB policy on physician illness and impairment. Anyway, it mentions that the PHP needs to function in a stable environment, insulated from political pressures. And that, I think that's exactly what was stated, is that there have been political pressure to inhibit the proper functioning of a PHP in California. The goals and missions of the FSMB and the FSPHP align in many ways. So it's especially true with respect to a desire to see healthy physicians providing excellent care to the patients they serve. So again, that positive angle needs to be emphasized, that boards create positive atmospheres for physicians to get care and be healthy, and that protects patients. Let's see, gotta make that go forward. And then, this is another really important thing, is that the PHP, if it's created properly, is empowered to take action, unlike what the board can do, because it's not encumbered by the legal constraints. So I've seen in my 10 years of being here in California that with the dissolution of the physician health program, it allows doctors to be having trouble that are sometimes a risk much longer than if a physician health program was present where they can intervene right away, because they don't, physician health programs don't have the legal constraints of due process. It's a clinical program. So they can intervene and get help for people much faster than the board, because the board, you know, I know they're busy, and it takes a year or two sometimes for the board to get around to following up on concerns about physician impairment. So here are some statements from the Center for Public Interest Law. This is one of the consumer advocacy groups that's been so vocal about this subject. You know, they've said that patients become the unwitting guinea pigs for these programs, meaning the physician health programs, and that is unacceptable. The very last thing the board should do is secretly divert the practitioner into a confidential program that will allow the individual to escape consequences and accountability. So again, opposing this kind of help for physicians. And physician health programs are a very uncomfortable problem, a dirty little secret. So, you know, real contrary to what the Federation of State Medical Boards has put out promoting these programs. This is from an attorney that is online, I think well said that, and this is what I think Mr. Pacifica was talking about, is if we go forward with a physician health program that's so encumbered by all these things mentioned here, I won't go through them all, it won't be confidential, you know, and so forth, it's going to be unlikely that anybody's going to want to be in that program. So it's not going to accomplish the goal that it's intended for. And I'll just skip over that. So anyway, I'm going to get to the solution here. I think the medical board should resist pressure from consumer groups in the media that they're only there to protect the public and not to assist physicians. So I've heard that said so many times in board meetings, and I think the board should not buy it. And, you know, I was at a lecture a couple years ago when it was a combined lecture between the FSPHP and the FSMB, where somebody stood up and said, you know, but we have these consumer groups opposing us developing a physician health program. What should we do? And the speaker said, ignore them. And I kind of think that's right. But I know that's hard because of how it's configured. Sure, the primary calling of the board is to protect the public, but they should also help physicians. I think we've driven that home enough. And these goals are not in conflict. They are aligned. Healthy doctors provide better medical care, and promoting policies that encourage doctors to get help early actually protects patients. Boards should not be ashamed to say that they promote physician health and well-being, and I'm so glad to hear that they're not. Their policies should reflect that they are aware that doctors have difficulties, of course, and promote programs that encourage doctors to obtain help early. So putting our head in the sand and acting like we only want perfectly healthy doctors practicing is not reality. You know, there's a sizable amount of doctors that are having difficulty, and we need to encourage them to face that and get help. And that's only going to happen if the board adopts a different posture that really promotes physician health. So the board should not be seen as the enemy of the licensees. Doctors should know that the board wants to support them and improve their health and well-being as part of their effort to protect the public and promote access to quality care, which is another aspect of their mission. So that's it. I'd like anybody else to comment. We have a small group here, so it'd be anyone else that has comments would be welcome. just unmute and speak if you like.
Mike Schwartz, I totally support what's been said here today. I have both personally and professionally seen both adversarial and supportive boards and PHPs, and there is absolutely a stark difference in physician or healthcare provider willingness to participate based on their level of fear. And I think that's what we're talking about. If you create an odious system, you are going to drive people underground. I don't think that's news to anybody on this link, or at least it shouldn't be. And they are going to get worse, not better. I don't think that these same groups who are bastions of protecting the public would be quick to say we should expose all of the private patients who have these problems. Are they also, honing in on teachers? I think a teacher who has that sort of responsibility is just as much at risk to cause harm, maybe even on a deeper level that we won't know for years. That's just an example. I mean, you can name just about any safety sensitive position, and what is that anyway? I think you can extrapolate. There are a lot of positions that are safety sensitive. If somebody's working in a factory and they are doing a bad job and it's not caught by quality control, that could kill somebody just as easily. Probably more, it would be easier than for a doctor to cause harm. I think there are a lot of stopgap and safety systems in medicine that are built in. I think that in the rare solo practitioner that we have is always a problem. But I think in most systems and most employers, I think they do have some extra safeguard measures. So I think that I totally agree with Dr. Skipper. And he is one of the men who was ahead of his time, as far as I'm concerned, in approaching people who were struggling. It's not to punish. It really needs to be the focus on what can we do. When I do healthcare evaluations for different boards and PHPs, I specifically approach the patient. The idea is to have you have a pathway to protect your license and to protect the patient, both, to help you get well. And I think if that's the message that can be carried, there'll be a lot more people that will reach out for help when they need it. Thanks.
Thanks, Mike. I think that's really interesting what you said. It brings to mind the whole issue we're facing right now with the police. There's a small number of policemen that are bad, that should not be policemen. But to throw the, baby out with the bathwater is totally inappropriate, in my opinion. I don't want to get into current politics too much, but it is a similar kind of situation. Anybody else have comments or questions?
I'll comment.
Thanks,
for what it's
Jill.
worth.
Thanks.
Of course, I agree with Dr. Skipper, but I'll just say from a personal perspective, since we have I can't imagine not having a physician's health program because, I had a problem and went through the physician's health program and never had an issue with the board. And I worked with the physician's health program and things got resolved and I was healthy and have been well for almost 20 years now, and went on to work with them and I'm on their wellness committee and everything's fine. And my husband, he had some issues too, and he had depression and was very, very afraid to, say something about it. And so, because of fear of what would happen. And my husband and I do some counseling with couples that are in crisis at our church. And we're currently working with a couple that he is an extremely high-powered attorney that travels all over the country and is very well known. And he has problems with addiction and other things. And he's very enabled, and he's very, he's a very sick person. But the lawyer assistance program and the lawyer board, whatever it's called, they don't support the board. Their board does not support wellness. It's just punitive. And so this has been going on with them for 8 years because he's just, they're not willing to go that route. I mean, if they had a supportive lawyer assistance program, he could have gotten help. So I don't understand. So I guess what I'm saying is, if there's no physicians, if a place doesn't have a physician's health program, then it's up to the board to take on the responsibility of knowing and understanding which doctors need help and how to get them help, and also knowing to be able to discern those few doctors that are, because everybody needs accountability, and everybody, there are some really bad doctors, and those people do need to be called out, but there's a lot of doctors that just need help, and they need a safe place to go to get it. I hope that made sense. It's pretty third grade level, but that's what I think.
Thanks, Jill.
You always laugh at me.
I love you. So, any other comments or questions?
Gabe Good here. Question I had about one of your slides had statistics based that suggested a certain percentage of physicians, both male and female, experience depression, and then 45% of anesthesiologists experiencing anhedonia. Is there any statistics along those that suggest, the work, the amount of work, the number of hours worked was the cause and or result of the anhedonia or depression? Or is this statistics and numbers suggestive that the person working those jobs had that as an underlying issue?
I don't think it clearly defines that. Maybe there's other articles that do, but the one I cited was simply a survey to ask people about their mental health.
Yeah.
So it wasn't clear, but I think you're bringing up some important points.
Certainly would potentially help in a treatment goal, right?
Right.
Analyzing that which is potentially trauma related, though it may be experienced differently for a physician, which really kind of segues into the next point, which I think changing sort of the narrative, understandably in a treatment setting, like-minded individuals paired with other individuals of similar caliber is probably a good thing to strive for. But even as we kind of go through this topic of distinguishing what the board covers, right? Protection of the public versus protection of the physician. But aside from license, is a physician nothing more than a member of the public, right? And so really, I think that, and interestingly enough, you brought up policemen. I mean, really, if you want to boil it all down, it's simply, human being to human being, we all sort of suffer, right, in our own ways with various components, and really viewing, potentially changing sort of that stigma or even the interpretation of what is needed for individuals is really kind of looking at them at a more human level, regardless of license. Now, of course, with that being said, very similar to military personnel, I feel as a treatment protocol, there should always be those suited to work with those who have, certain degrees, whatever you have that really separates you from, the next individual. I feel like there should be like-minded individuals treating those, but in the grand scheme, really recognizing and changing the perception of one over the other as being anything more than, groups of humans that need that help and really navigating that. I think it could be something helpful.
Thanks for that input. Mr. Prosifica?
Sorry, can I get another word here? I just think
You
it's
betcha.
very helpful just to clarify some of the issues that are sometimes the source of misunderstanding. When we say that protecting patients and helping doctors are not in conflict, it's important to clarify by helping doctors, we don't mean it's the role of the board to perform the job typically of a trade association or a representational body. We're not here to negotiate terms of practice or, HR. That's a whole nother set. But what we're talking about is to ensure that at every step of professional development, that there are adequate resources in terms of development of an ethos of professionalism, acquiring the necessary clinical skills, having set aside time for training and mentoring, having adequate resources. So it's important to make that distinction. I think, secondly, it's not a question of either or, adversarial or non-adversarial. It's the case that there are some cases which require an adversarial procedure. We have a small number of doctors, frankly, who engage in criminal behavior. You have one regulatory model there, but certainly it is my experience that there is also need for a significant non-adversarial process and that we need a rebalancing there. And finally, I think to bring all these concepts home, there is one concept that made a powerful impression upon me as my development as a medical regulator, and that's the second victim syndrome. I'm not sure how well that is known here, but it arises out of a case of Kimberly Hyatt, who was a nurse of 25 years, unblemished record at Seattle Children's Hospital. She had a momentary lapse of concentration, injected an infant with 10 times the recommended dose. It was not proven that it caused patient harm, but needless to say, it didn't help the infant, who then ultimately died, but who had been very sick. She was suspended. She was given very onerous terms and conditions, and within 6 months, she committed suicide. The public is not helped by that. The public is not helped if any healthcare professional believes if they make one mistake, their professional life is over. And that's a message that has to be driven, and we have to get that across.
Thank you so much. Well, I think that is probably a good place to stop. I do appreciate everybody's participation today. You guys have been great, and I think this is an important topic that that I am so glad to hear is that you all are in agreement. So let's all move forward and try to make this happen. Thank you
Greg,
so
we
much.
did have some comments in the chat real quick, if you want to take a look.
Okay. Oh, okay. Let's see. Let's see. Oh yeah, don't forget legislators. Yeah, legislators have problems too, right? All the physicians that I know that are burned out and depressed are that way due to the increasing demands placed on them by administration. The almighty dollar being controlled, being forced to work more hours, be less thorough, and feeling they can't do a good job. So yeah, there's those pressures for sure. I just think that that doctors need encouragement and support. And I'm so glad to hear from a executive director of a board that he agrees and cares. And I think we're going to improve patient care in this country if we start supporting doctors more. So
Greg,
thanks, everybody. Yeah.
Hey, Greg, this is Gail's voice. I wonder if before you end, we might ask Mr. Prasivka one more question.
Sure.
If you have seen and heard from this conversation and maybe from some others, your open meeting, your new schedule of hearing from the public, if you have heard all from that, do you have thoughts now about how these folks can assist you and the board? Because we know that it is your priority to get this legislation up and running and then tinker with it. How might this group of interested persons in California be supportive and move that forward?
Yeah, maybe just a quick little bit of background here. Because of the Open Meetings Act, our board meetings tend to have a high level of participation by public interest members, by patient advocate groups, self-described, and they generally, not exclusively, but generally are heavily weighted toward those who believe we must have significant increase in our disciplinary rate. What we have done, and which we started to do just this year, is to have separate meetings of public stakeholders, inviting them to participate. I think one thing which would be very helpful for the board is if we had increased participation from other public interest groups who have a different point of view, to give the board a more balanced outlook. There are patient safety groups, and I know them from my work when I was in Ireland before, who don't see the patient advocacy model as a disciplinary one, but as one in which the focus is on trying to develop insight from, let's just say, a poor outcome. What do you learn from that? How do we ensure it doesn't happen again? What, in particular, what insight can the physician develop? So I think in terms of supporting the board, I would invite, if either some members here would like to participate, or if they could reach out to other groups who they know would be in a position to participate. And so at least there's more balance in the public interest position. I think that would be very helpful.
So you're talking about inviting people to make presentations at the stakeholders meeting, the quarterly stakeholders meeting, or are you also talking about the regular board meetings?
Well, first of all, they are completely able to participate in the regular board meetings. They can do that now. But I would particularly like them to think about attending our public interest stakeholder meetings as well.
Great.
Okay, and the next one I believe is, I used to have the date in my mind. I thought it was August something, but I'll be happy.
Well, sorry, the next board meeting is in August, but we're planning to have another public interest stakeholder meeting about 2 or 3 weeks before. That date has not been set, but that's when it's anticipated it's going to be. That's the public interest meeting.
Okay. We'll get that. We'll get that date circulated.
Very good. Thank you.
Thanks so much for everybody's input. I really appreciate it.
Greg,
have a
can
good
I
day.
add one thing?
Oh, sure. Mike.
I'm sorry. I'd especially like to remind everybody, especially when legislatures get involved or even boards, a lot of money is invested in training healthcare professionals. Are we just going to throw that money away and say, well, we're going to cancel that person and start over? Or are we going to find a way to rehabilitate that person, to make sure they're safe, to monitor them, and to have a pathway to succeed? I think if somebody did a cost analysis over treating a struggling healthcare professional versus just tossing it away and starting from scratch with an unknown. You know, I can personally say, if I'm going to have a surgery, I want that surgeon to be in recovery from mental health or addiction, and I want that anesthesiologist who's putting me to sleep to be in recovery too, because I know about them. I don't know about the ones who may be struggling, who aren't saying anything and aren't reaching out. I think there are some very practical considerations that I think need to be discussed at the board and the legislative level before they go off and say, we're going to come down on this profession or that profession. That's just, sorry if I said too much today, but.
Well, again, thanks everybody, and especially you guys that aren't from California. We've sort of dominated this with the California issues, but they're prevalent all over the country in different ways. So everybody have a good day. Thank you so much for participating, and we'll be letting you know about future webinars. Appreciate it.
Thanks,
Okay.
Greg.
Thank you.
Thank you.
Cheers. Bye.
Bye-bye.